A young adult presents in severe respiratory failure, fighting a stubborn chest infection. They're slowly suffocating under the weight of their own secretions. This overwhelming physical collapse is driven entirely by an autosomal recessive genetic condition, cystic fibrosis. The disease originates from a specific error on chromosome 7. In the vast majority of cases, it is a 3-base pair deletion known as the delta F508 mutation on the CFTR gene. That single genetic edit triggers a reliable triad of clinical consequences. Patients suffer from thick mechanical blockages, chronic microbial infections, and severe nutritional malabsorption. The diverse, life-threatening symptoms seen at the bedside are all predictable, cascading consequences of this one microscopic error. To understand the pathology, we have to establish the normal baseline. The CFTR protein functions as a chloride channel on the pulmonary epithelium. It actively pumps negatively charged chloride ions out of the cell. Through basic osmosis, water molecules track those ions, perfectly hydrating the mucosal layer above. The delta F508 mutation breaks this mechanism. The defective CFTR channel misfolds and fails to traffic to the cell membrane. Without the channel, chloride ions are trapped inside the intracellular space. Because the ions remain inside, the osmotic gradient reverses direction. Water is pulled out of the extracellular space and back into the cell, entirely dehydrating the airway surface. The liquid mucosa layer instantly solidifies into a dense, viscous gel. This static, dehydrated mucus paralyzes the local cilia. It traps incoming pathogens and creates an ideal breeding ground for bacteria to rapidly multiply, shield it from normal immune clearance. The failure of this microscopic osmotic gradient is the mechanical root cause of all macroscopic CF morbidity and mortality. In the lungs, this thick mucus physically obstructs the airways. The persistent presence of bacteria drives chronic inflammation, ultimately destroying the lung architecture and causing permanent bronchiectasis. But the CFTR channel is not confined to the respiratory tract. In the gastrointestinal system, the exact same osmotic failure causes thick, dehydrated secretions to plug the tiny ductules of the pancreas. Blocked from reaching the intestines, digestive enzymes remain trapped in the pancreas, leading to severe pancreatic insufficiency and an inability to absorb fats and vital nutrients. The liver is similarly compromised. Defective CFTR proteins on the epithelial cells of the bile ducts lead to thickened bile, causing stasis, cholestasis, and eventual liver disease. The singular molecular defect starves the patient's body of nutrients from the inside, while simultaneously drowning their lungs in static, infected fluid. Identifying this disease requires measuring that precise ionic failure. The gold standard diagnostic tool is the sweat chloride test, conducted using pilocarpine iontophoresis to stimulate sweat production. This diagnostic criteria document details the strict thresholds. A sweat chloride value of 60 millimoles per liter or greater confirms the diagnosis. Conversely, a value of 29 millimoles per liter or lower is normal and is sufficient evidence to rule out cystic fibrosis entirely. Beyond the lungs and digestion, the disease heavily impacts reproduction. Approximately 98% of adult males with CF are infertile. This is not a failure of sperm production. The thickened secretions during fetal development cause a structural defect called congenital bilateral absence of the vas deferens. The sperm are produced, but they are physically blocked from exiting, resulting in obstructive azoospermia. Even when a patient's primary clinical complaint is an anatomical reproductive issue, definitive diagnosis still relies on measuring the initial ionic failure through the sweat test. The clinical presentation evolves predictably with age. In infancy and early childhood, the classic signs point to severe digestive blockage, a failure to thrive, foul-smelling steatorrhea, and delayed passage of meconium. These early symptoms are the direct result of pancreatic insufficiency. Without a functioning pancreas to process fats, these infants require urgent, lifelong supplementation of fat-soluble vitamins A, D, E, and K. This clinical text outlines the respiratory progression. In early life, the stagnant mucus is primarily colonized by Staphylococcus aureus. In this pediatric stage, the mechanical blockage primarily threatens the patient's nutritional trajectory, establishing the baseline damage while setting the stage for the first wave of respiratory colonization. As the patient survives into late adolescence and adulthood, the clinical profile undergoes a severe shift. The cumulative damage to the organs begins to trigger secondary systemic failures. The trapped digestive enzymes gradually destroy the pancreas, leading to massive endocrine failure. By age 25, over 65% of CF patients develop CF-related diabetes and require insulin therapy. Simultaneously, the microbiology of the lungs shifts. According to the medical literature, after age 10, Pseudomonas aeruginosa takes over as the dominant chronic colonizer in the majority of patients. As the patient matures, the clinical strategy must pivot from primarily managing their early malnutrition to fighting highly resistant chronic pulmonary infections and failing endocrine systems. Managing the disease requires aggressive intervention. On a mechanical level, patients rely on daily chest physiotherapy and postural drainage to physically dislodge the static secretions. This management guideline highlights the pharmacological approach. The first-line mucoactive agent used to chemically thin the dense mucus is recombinant human DNase, or Dornase alpha. Modern medicine has also developed upstream molecular correctors. The combination therapy lumacaftor-ivacaftor specifically targets the delta F508 mutation, improving the conformational stability of the CFTR protein and increasing its successful transit to the cell surface. Even with optimal therapy, acute emergencies occur. This text identifies distal intestinal obstruction syndrome, or DIOS, as the most common bowel complication in adult patients, presenting in frequency directly behind gastroesophageal reflux disease. Modern CF care dictates a dual-pronged approach, aggressively breaking down the downstream mechanical blockages in the lungs and gut, while deploying targeted agents to correct the upstream molecular defect at the cellular membrane. Despite aggressive management, pulmonary function eventually declines. When respiratory failure becomes irreversible, a lung transplant is the final palliative surgical option. These surgical guidelines specify the strict functional thresholds for consideration, an FEV1 falling below 50% predicted with a rapid decline, or an FEV1 below 40% combined with severe malnutrition, indicated by a BMI under 18. Eligibility for surgery is heavily dependent on microbiological history. This text isolates Burkholderia cepacia as the ultimate red flag, associated with the worst prognosis. Because it severely impacts survival, it is a relative contraindication to receiving a lung transplant. A patient's exact microbial colonization history directly dictates their eligibility for life-saving surgical intervention. Let's lock in the high-yield facts for the exams. First, what is the most common colonizing organism in adult CF patients? The answer is Pseudomonas aeruginosa. Question 2. What is the specific anatomical cause of male infertility? Congenital bilateral absence of the vas deferens. Finally, question 3. What's the diagnostic threshold for a positive SWITE test? The threshold is 60 millimoles per liter or greater. To anchor this, use the CF pump heuristic. C for chloride channel defect, F for delta F508 mutation, P for pancreatic insufficiency, U for upper and lower respiratory infections, male for male infertility, and pilocarpine for a sweat test. Treating cystic fibrosis demands rigorous, multidisciplinary vigilance. You are counteracting a relentless cellular defect that systematically breaks down the body, from the first breath to the final surgical intervention.